Hello, my name is Darren Zaranek from the University of Michigan, and I am one of the co-chairs of the INPCS Science Committee. I am honored and delighted to have the opportunity to introduce Dr. Laura Hanson as the winner of this year's INPCS Outstanding Scientific Contribution Award. Dr. Hanson is a tenured professor in the Division of Geriatric Medicine, Department of Medicine at the University of North Carolina, Chapel Hill. She was a founding co-director of the UNC Palliative Care Program. Her career has included multiple NIH-funded grants focused on improving dementia palliative care for both patients and caregivers. She is also one of the leaders of the Palliative Care Research Cooperative Measurement Corps, which demonstrates her commitment to helping other researchers conduct high-quality projects to ultimately improve care for our patients. In discussing her nomination for this award, her colleagues commented on her incredible kindness in all interactions, as well as her tremendous responsiveness and commitment to helping junior trainees. And so, in recognition for the totality of her efforts in promoting high-quality science in neuropalliative care, I am delighted to present the INPCS Outstanding Scientific Contribution Award to Dr. Laura Hanson.
Welcome, everyone. And thank you so much for this honor of receiving the INPCS Outstanding Scientific Contribution Award. I was very surprised to receive the award, and I'm delighted to be able to talk with you today. The title of my presentation is Guided by Suffering, Designing Neuropalliative Care Interventions. And my goal is to talk through what I understand about the experience of suffering in dementia, which is the focus of my neuropalliative care research, and talk about interventions that are being developed to try and address that. These are my current and most recent funding sources, and I have no financial conflicts to report with this presentation. And I'm going to take the liberty of dedicating this presentation to two people who I love very, very much, Pam and Carl Hanson, my parents. When I was asked to give this presentation, they immediately came to mind as someone I need to thank for supporting me and allowing me to arrive at the opportunity that I now find myself presented with. I also want to honor them by saying that I've always admired both of them as remarkable individuals, but my mother, a very strong woman, currently has dementia, and I cannot help but think of her and think of my father, her devoted care partner, while I talk about this disease. My objectives are to discuss with you the trajectory and the prognosis of Alzheimer's disease and related dementias, or ADRD, then to talk some about the sources of suffering that occur in this disease, and then focus on selected palliative care interventions that I believe are beginning to help us provide comfort and support in ADRD. And along the way, I'll reflect on implications for neuropalliative care, both in clinical care and in research. I'll start off by saying that dementia is multiple diseases. As many of you know, dementia is really an umbrella term. I'm going to use it as I talk, and we all use this term clinically, but it really encompasses many diseases, including Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, and many, many other causes. As dementia progresses along its course, these diseases become indistinguishable, and mixed pathology is very common on autopsy at death. As well, clinical features merge in late-stage disease. It's also really important to think about the fact that ADRD has extraordinary impact on our healthcare system. There are currently over 6 million Americans living with dementia, over 1 million with late-stage dementia, and annual costs for this condition run between 150 and $200 billion. This is a population that has very complex healthcare utilization. When I want to work in oncology palliative care, I know right where to find patients with cancer. They're in the oncologist's office or they're on the oncology unit in the hospital. But when I want to work to support people with ADRD, they are all over our healthcare system. The majority of their care actually comes from primary care providers, but they also encounter neurologists, psychiatrists, geriatricians who take care of various parts of their needs. They transition frequently between settings, the emergency department, the hospital, long-term care, and home. And so we find them everywhere we go in healthcare. Not surprisingly, because of all this complexity, they receive care that is poorly matched to their needs and goals, and they experience suffering, both the individual with ADRD as well as their families. I don't have to tell this group that this population also causes a great deal of moral distress for clinicians as we struggle to provide them good care in a healthcare system that really does not match to their needs. And then finally, I want to point out that essentially everything we provide in ADRD is palliative care. This is a major serious illness that has no effective pharmacologic treatment. All right, I'm going to spend a little time talking about the trajectory and prognosis of ADRD, which I, as a palliative medicine physician, view as foundational to anything else that I do in palliative care. You're all, I'm sure, familiar with staging systems that describe how people move through the trajectory of dementia. From stage 1 with no cognitive decline, but the budding pathology in the brain, to stage 7 with very severe cognitive decline. To date, most of the work that's been done on dementia palliative care is concentrated on this very last stage of disease. But as we talk today, I want you to think and reflect on the trajectory of this illness and ways that palliative care matter along the course. Another thing to say about this disease and its prognosis is that prognosis is not just about life expectancy. It's also about the trajectory of functional dependency in a given disease. In diseases that cause sudden death, as illustrated on the far left of this graphic, individuals experience dependency or ADL disability on the y-axis only at the very end of life, just before the time of death. In cancer, that ADL disability might accrue in the last year of life, as illustrated across the x-axis. In organ failure diseases, maybe a couple of years before death. But in dementia, illustrated in the 5th box, as you can see, ADL dependency results from the disease for many years leading up to the time of death. And this has huge implications for how they receive care. It also is noticeable that there's no end-of-life inflection point in their functional disability. And I'll talk about that just a little bit more. We know that in terms of life expectancy from the time of diagnosis is years of time for people with ADRD. But in the last stage that we know how to describe for this disease, stage 7, the median survival remains over a year's time. Another way of saying that is 6-month mortality risk at stage 7 is 25%. 25% are likely to die in the coming 6 months. And that percentage increases if they also have persistent feeding problems, febrile illnesses, pneumonias, hospitalization for severe pneumonia, or hip fracture. But you can see from this information that if we only describe somebody as stage 7 ADRD, their trajectory and prognosis doesn't fit the hospice prognosis criterion of 6 months or less. Hospice prognosis for ADRD requires that an individual is stage 7 in the progression of the disease, and also that they have impaired nutritional status or recurrent infections or advanced stage decubitus ulcers. And quite frankly, many people with ADRD never qualify for hospice based on this diagnosis. It means that many of them fail to access hospice services, which is the most universal form of palliative care available in the United States. People with ADRD instead often qualify for hospice based on a comorbid diagnosis, if they qualify at all. So let me pause for a moment and just share a few reflections on ADRD prognosis. For clinical palliative care, I think that this means we need to do a much better job when working with people with ADRD of assessing their baseline function and documenting ADRD stage in clinical practice. If we want to talk about prognosis for hospice referral or other reasons, we have to know ADRD stage and also take into account comorbid medical conditions. And as the director of a specialty palliative care program, I'm here to tell you that I really cannot buy into the idea that we would prioritize access to specialty palliative care based on life expectancy for this population, because we really can't identify life expectancy. But instead, we should really think about palliative care interventions based on suffering. For ADRD palliative care research, it means that we have to incorporate medical complications of ADRD into prognostic models and incorporate comorbid medical conditions into those same prognostic models if we're going to have any better sense of life expectancy prediction. And it also, in my mind, means we need innovation in hospice and palliative care models, because if we rely on 6-month prognosis, we will miss the opportunity to reach out and help this population. I've put a little citation at the bottom of this slide because I really want to highlight, I'm going to give you some reflections in my ways of thinking about this disease, but I want to highlight Claire Kreutzfeld, Benzie, Kluger et al., and their publication in Neurology 2018, in which they, I believe, have really given us a call to arms for neuropalliative care that touches on many of the points I'll make. All right, I'm going to shift from prognosis and talk about suffering in ADRD. The reason I want to talk about suffering is because we're the Neuropalliative Care Society. And if we stop and think about what palliative care is, it's interdisciplinary care focused on improving key outcomes of comfort and quality of life. We try to impact those outcomes by providing expert pain and symptom management, goals of care and treatment decision support, and emotional and spiritual and practical forms of support. I've added at the bottom of the slide the way that I explain this mystery to patients and families who've never heard of palliative care, but I know I don't need to do that for this group of people. It's also important to recognize who provides palliative care. This is, again, very important because of what I've told you about where the ADRD population receives care. There are specialists in palliative care and hospice, and I count myself among those who are available to provide care in specific settings. But the ADRD population is so large and scattered across our complex healthcare system. And we know much of their palliative care is secondary palliative care, provided by clinicians who routinely see patients with serious illness in neurology practice or geriatrics practice or psychiatry practice. And then finally, palliative care is provided by all clinicians because this patient population is found in all settings. So if we're thinking about palliative care for this population, we should be guided by an understanding of suffering, first and foremost for the person with ADRD. A person who is diagnosed with ADRD experiences extraordinary losses. They experience losses in terms of personhood, in terms of their roles in society, and their ability to function and get through the day. They experience physical symptoms, physical pain, dysphagia and weight loss and dehydration are common symptoms, but they experience all the other physical symptoms you can imagine: shortness of breath, constipation, nausea. We all know that neuropsychiatric symptom distress and the diversity of these symptoms is a major part of suffering for the person with ADRD. And these symptoms morph and shift and change over the course of the disease. They may have anxiety and depression, physical restlessness, akathisia. They may resist personal care and become distressed by personal care. They may experience delusions, hallucinations, or sleep disruption. And then finally, they experience many medical complications as that command and control center in the brain gradually causes the body to weaken. They experience infections, falls, injury, dehydration, and other things that cause them suffering. They don't suffer alone, though. They cannot survive in this world without their family, without care partners, who also have demonstrable suffering as a result of this disease. They experience measurable stress. They experience physical health impacts as a result of having an unpaid part-time job for several years of time, providing practical daily care, emotional support, care coordination, surrogate decision-making in healthcare. To add insult to injury, the family is bearing the highest out-of-pocket costs of any serious illness, up to $100,000 of out-of-pocket costs in the last year of life. And I'll never forget this phrase that an advisor to my research team, a care partner advisor, told me when talking about the family experience. She said, with reflection on her role as a care partner for her mother, we became healthcare nomads. They could no longer go to the primary care provider because a 15-minute appointment in a crowded office was intolerable and, frankly, useless. And they made frequent transitions between different healthcare settings with the care partner herself functioning as the care coordinator because no one else was able to do that job. So as a result of this suffering and as a result of characteristics of the disease, I would argue that people with ADRD have really unique palliative care needs. In terms of prognosis, I've already described for you that they have a prolonged course without a distinct terminal phase. I think you also know, but I want to emphasize, that death for this population is caused by treatable acute illnesses, falls and fractures, pneumonia, other infections. And each time it seems likely to the family or to the healthcare provider that this is something we can get turned around. But at some point, one of those treatable acute illnesses will actually be the cause of death. Goals of care decisions for this population include decisions about CPR and intensive care, but also ordinary care decisions about feeding options or antibiotics, or even coming to the hospital at all. And these decisions are proxy decisions. The patient's voice is lacking for years before the decisions are necessary. And as a result, the surrogate or proxy decision maker, the family member, suffers a lot of ethical and emotional distress as they attempt to make good choices with no patient to consult with. Care partners, as I've already emphasized, are very stressed by their role. And then there are unique palliative care needs in symptom management. This is a population for whom physical and neuropsychiatric symptoms often co-occur. We can't think of the physical and the neuropsychiatric as separate. We have to use nonverbal assessment skills because these patients can no longer tell us about their suffering. And non-pharmacologic treatments are really essential, but difficult to deliver. So, a pause for a couple of reflections on suffering in ADRD. For clinical palliative care, I would argue that the first thing we need to do is address suffering for the person with ADRD. We need to walk in the room, make a careful assessment, and treat symptoms first. Secondly, we need to address suffering for their care partner. We need to do all of this before we attempt a goals of care conversation or advanced care planning. And we need to be thoughtful about extending palliative care across settings, since these individuals will not stay in the place where we meet them first. For ADRD palliative care research, we need to be thinking all the time about addressing dyads, the person with ADRD plus their care partner, whether we're measuring outcomes or designing interventions. We also need to consider the balance between primary and secondary palliative care interventions versus the aspects of palliative care that should be reserved for specialists in palliative care. And then, like clinical care, we need to design more research that crosses settings of care rather than remaining siloed in the nursing home or the clinic or the hospital. All right, finally, getting to the good stuff, we'll talk some about palliative care interventions. I am going to selectively review a few interventions, but before I do that, I want to point you toward this recent AHRQ review of dementia care interventions. It's a very comprehensive review published in 2020, and it covers a wide range of types of interventions in dementia care, which arguably themselves really are part of palliation. Things like music therapy or support interventions for caregivers. I'll highlight two topics here that were reviewed in this comprehensive review that you could say are distinct to palliative care, advanced care planning interventions, and palliative care interventions. And you can see by what I've summarized here that even within advanced care planning and palliative care, we have a lot of room for further research. I'm going to walk through interventions by thinking about the different stages of ADRD. As I said before, we've concentrated our focus on stage 7 disease, but there are many palliative care needs across the trajectory. So in early stage ADRD, people have mild memory loss, subtle language and perceptual problems. They struggle to initiate or organize their common activities, and they experience emotional distress as a result. They need help with really complex tasks. Palliative care needs at this early stage are arguably these: The person with ADRD can still participate, and they and their care partner need help understanding the nature of the diagnosis and what prognosis is, what this disease holds for them in the future. They need help with advanced care planning for healthcare decisions, but arguably also for care and finances because of the impact that the disease will have in the future. And this is a time for medication safety review because these individuals are dealing with other health problems. They're often taking many medications, but those medications are becoming less and less appropriate or safe for them. Just to take an example of advanced care planning, decisions in early dementia are really important to prepare for a time when the person cannot speak for themselves in the future. If we take a narrow definition of advanced care planning, we'd be encouraging the healthcare power of attorney, healthcare decision maker decision, the living will decisions. But I would argue that there's room here clinically and in research for other planning, including for powers of attorney, providing preparation and planning to understand the illness trajectory, and providing information and preparation for future care needs. We have a real gap. We have very few interventions for information sharing, preparation, and advanced care planning in early stage dementia. Let's move a little further down the trajectory of this disease. Let's say 3 years later, the same individual needs help with dressing and bathing. They recognize family and close friends, but they're struggling to remember other people or keep track of recent events. And not surprisingly, they're talking more about the past than about the present, which has become more confusing. This is moderate stage ADRD, and people have memory loss and orientation problems that are affecting their daily life. They have language problems that affect daily communication. They experience distress and anxiety, and they need help with simple daily tasks. Palliative care needs transform. Symptom management becomes management of anxiety and depressive symptoms. This is a very awkward phase for the relationship between the person with ADRD and their care partner because of the changing capacity for decision making. The person with ADRD naturally is clinging to independence and autonomy and the ability to control their own choices and their own life, while their care partner and the healthcare system are pushing for safety in areas like medication management, driving, and healthcare decisions. And this is a time when increased care partner support is necessary. In symptom management at this stage, it's important to recognize that about a quarter of people with ADRD will have depression and depressive symptoms, but it often seems like anxiety. It signals a need for increased support as they react to a world around them that is out of their control. There have been antidepressant medication trials for this population, but these show questionable benefit and won't surprise this group that that's true. These are medications designed to affect neurotransmitters in a healthy brain, but the brain that they're landing on no longer has the same kind of neurotransmitter profile. There's, from clinical trials, some promise in non-medication interventions for anxiety and depression. Cognitive stimulation, social stimulation, massage therapy, exercise interventions, and reminiscence therapy are key examples. We know we have to avoid anti-anxiety medication. Antidepressants may not be all that effective, but if we want to provide expert symptom management in anxiety and depression, we have a real gap. because these non-medication interventions are exciting and innovative, but we have yet to have a mechanism by which these become pragmatic and sustainable in real-world clinical practice. I mentioned at this phase this changing capacity for decision-making that's affecting both the care partner who takes over more and more and the person with ADRD. They are making a transition in decision-making control. Ideally, this is done by respectfully including the person with ADRD along the way while engaging and supporting the care partner more and more in healthcare encounters. The care partner takes over major healthcare decisions, care coordination, financial decisions, and that very tricky area, driving. But again, we see gaps. We see gaps in clinical care and research. We really do not have a systematic approach for care partner inclusion in dementia care. Goodness knows, often we open the EHR and we can't even see who the care partner is or should be. We also have a gap in driving safety interventions for this population, leaving that awkward and difficult transition to a healthcare provider and a care partner. And it would be lovely to see these gaps filled in enhancing the quality of dementia care. There have been some wonderful care partner support interventions, and I highlight here the COPE and REACH2 randomized controlled trials that enrolled caregiver and dementia patient dyads at all stages of dementia with psychosocial support sessions, and with the COPE trial added occupational therapy training. These interventions are successful at improving caregiver outcomes, and that's very exciting. But again, we have a challenge in a pragmatic mechanism to make this kind of psychosocial support universally available. All right, moving into the later stages. After 6 years, this individual now needs help every day for basic activities. They might still know close family, but they're also experiencing more neuropsychiatric distress. This phase of late-stage ADRD has been a focus for research and for clinical innovation. In late-stage ADRD, the person is disoriented to much of what surrounds them. They have major communication impairment, sleep-wake disturbance, incontinence, things that are extremely stressful to the care partner and may result in placement in a long-term care setting. They have intensive physical and emotional symptoms. They need help all day, every day. And this is the stage in which falls, infections, and feeding issues become major problems. So what are the palliative care needs in late-stage ADRD? People need help around these medical complications and the healthcare transitions that accompany each acute episode. They need assistance with symptom management, both physical and neuropsychiatric. And this is the time when advanced care planning no longer makes sense. We're really talking about sophisticated goals of care interventions and complex treatment choices. I want to highlight that feeding issues are almost universal. Susan Mitchell's work shows us that over 80% of people with stage 7 ADRD have feeding problems. These are ethically and emotionally challenging for families. It's so difficult to watch an individual struggle to eat or refuse to eat. But we also know that for this population, tube feeding is ineffective and, if anything, associated with more complications. So the answer for this population is assisted oral feeding, consisting of a calm environment, plenty of time and assistance from another human being, and the right foods. In my own work, the first clinical trial that I conducted with this population was the Improving Decision-Making Study, as I became more and more interested in the way that I saw individuals dealing with feeding problems and family care partners suffering from their own distress over this choice. I designed and tested a decision aid that lays out the choice between tube feeding and assisted oral feeding for this population. And we conducted a clinical trial enrolling dyads of nursing home residents with stage 6 to 7 ADRD and a feeding problem, along with their proxy decision maker. The decision aid intervention was helpful in a variety of ways. It reduced decisional conflict. It increased discussions with the prescribers in the nursing home. It increased assisted feeding interventions, reduced weight loss, and not too surprisingly, had no effect on mortality outcomes. I've put the reference at the bottom of the slide, but also a reference to the OHRI center that collects decision aids, reviews them, and makes them publicly available. And this decision aid is stored there. As I was working on the feeding options decision aid, I heard from others about the need for a more comprehensive approach to decision-making that addressed the larger goals of care for people with dementia. And that led to my next clinical trial, a clinical trial of a decision aid about goals of care for this population. The Goals of Care study was a cluster randomized controlled trial conducted in 22 nursing home sites. We enrolled 302 surrogate decision makers for nursing home residents with late stage to advanced dementia. This time I widened the scope a little bit and included GDS 5 to 7. The decision aid was accompanied by a semi-structured care planning meeting between the nursing home staff and the family care partner. And our primary outcome was to examine communication quality with secondary outcomes of goals of care and treatment choices. In the Goals of Care study, our first main finding, and I was fascinated by this, was that the primary goal was comfort for most family caregivers when asked. It was 65% at the time of enrollment and rose to 79% of them by 9 months or the death of the person with ADRD. And this cut across the stages. At stage 5, it was still over 50% at enrollment. The Goals of Care decision aid plus the discussion with nursing home staff resulted in better quality communication, improved concordance on goals of care, increased palliative care content in the treatment plans. As a surprise to us, we also doubled the use of pulsed documentation in this population. I say a surprise, it was not intended. It was never mentioned in the decision aid itself, but staff in the nursing homes recognized that the goals of care discussion mirrored some of the content of pulsed and picked up its use. We also noticed a reduction in hospital transfers for this population as a result of the intervention. Then I want to sort of wrap this discussion up by talking about neuropsychiatric symptom distress, because as I was doing the clinical trials with decision aids and focusing on decision making, I kept returning as a clinician to suffering and to the concern that just addressing goals of care did not allow us to address suffering. We all know that neuropsychiatric symptoms are prevalent in late-stage dementia, with many underlying triggers for that neuropsychiatric distress: physical pain, delirium, poor quality personal care, environmental triggers, underlying akathisia, delusions, or hallucination. I personally in practice avoid the term agitation for this population because it's such an uninformative term and really can't guide intervention. We know that the backbone of treating neuropsychiatric symptoms is non-medication interventions. It's creating comfort in the environment and in interpersonal care. And I've highlighted here for you evidence from a number of recent systematic reviews that review the intervention literature in this area, indicating that if we treat pain and acute medical illnesses, if we use sensory modalities and compassionate interpersonal care, we are giving the most effective interventions to moderate this form of suffering. I want to highlight for you a clinical trial that is not from my group. It's from Norway, but is a cluster randomized controlled trial that I think serves as a model to help us think about the co-occurrence of pain and neuropsychiatric distress. In this trial, they enrolled nursing home residents with moderate to severe dementia who also were exhibiting distress behaviors. And the only intervention was a stepwise pain treatment protocol that began with scheduled Tylenol and escalated. Their outcomes improved at 8 weeks, with improvements in a standardized observation scale of pain behaviors, as well as distress behaviors and psychiatric symptoms. And I think this is a lovely trial to help us recognize that neuropsychiatric symptom distress may well be a cry for us to look at physical pain or other causes underlying the neuropsychiatric distress. I also want to tell you about a place that gets this right. So some of you may have heard of the Beatitudes in Phoenix, Arizona. The Beatitudes is a continuing care retirement community in Phoenix that for the last 20 years has been perfecting dementia palliative care as part of their practice. They are a remarkable team of individuals. And in their dementia units, you will not see them using medications for neuropsychiatric distress, and you will see really extraordinary approaches to interpersonal interaction. I was privileged to work with the team at Beatitudes. They call their program Comfort Matters, to develop a training program for nursing home staff that is video-based called Comfort First, that is illustrated with many of the techniques that are being used with this population at Beatitudes. And then finally, I want to highlight that I've moved on to the conduct of a large multi-site clinical trial of palliative care for people with late-stage Alzheimer's disease and related dementias funded by the NIA. The ADRDPC study, as we call it for short, is an ongoing study in which we anticipate enrolling 474 dyads of hospitalized patients with stage 5 to 7 ADRD, along with their family care partners. We've recently had a supplement awarded so that we can translate the whole protocol into Spanish and enroll Hispanic Latino dyads. And our intervention in this study is specialty palliative care plus transitional care. You can see our outcomes list here, but it purposefully includes outcomes for the person with ADRD and for the care partner. So I'll end with some further reflections on ADRD palliative care interventions. If we're intervening on the clinical side, I think it's really important to remember to assess neuropsychiatric and physical symptoms and to remember that they co-occur. If it's neuropsychiatric distress, think, is it pain? Is it constipation? Is it shortness of breath? Important also that non-pharmacologic interventions are essential to good care. They are difficult to implement, but that does not mean we should not try. And the transition from advanced care planning in early stage ADRD to goals of care decision-making in late stage is something that we should be looking at across the trajectory. In dementia palliative care research, there are many careers awaiting many investigators. We really need to be thoughtful about designing interventions across ADRD stages and across the settings where these individuals find themselves. And there are a number of gaps in intervention research that I've listed here. I bet you can think of just as many more. But thank you in the meantime for all that you do in neuropalliative care. I look forward to our discussion and our work together.
Okay, thank you, Laura. That was a wonderful talk. I have a page full of notes, and I would encourage people in the audience, if you have questions for Laura, to use the Q&A function on the right-hand side of your screen and put some questions in there. And I'm going to start with some questions from the audience, and then we'll get to some of my own questions of time. The first question comes from Farah, who's a friend and hospice physician. And I'll just read her question is, whenever I discuss advanced care planning, I always stress the importance of early discussions. However, due to the way palliative care is introduced, my actual work is mostly helping people who are relatively late. Recently, I've had the request to engage with people in early stages, and I found that advanced care planning discussions are more clunky and awkward than I expected. I found it hard to describe the variables in a meaningful, accessible way when they were so far off in the future. Any tips for effective advanced care planning discussions for early stage ADRD?
Farah, I love that question. I highlighted in the talk that we really don't have best practices in this area. And if you want to start developing them from your clinical practice experience, that would be wonderful. I agree with you completely that we ask people in early stage serious illness of any kind to deal with hypothetical questions. And we're simply not set up to be hypothetical about the future. It's honestly much easier to make decisions about what faces us immediately. I think in early stage advanced care planning, what I do clinically is ask a couple of types of questions. One type of question I ask people is to reflect on what makes life worth living and what defines quality of life for them. Because again, in palliative care, we're trying to support quality of life. And I want to know what defines quality of life for that person. And I might well record that in an advanced care planning note or encourage them to put it in an advanced directive. I think the second thing that I do in an advanced care planning conversation early on is I give people a few hypotheticals to consider. And those classic hypotheticals are situations where, number one, they have a very short time left to live regardless of medical intervention. Number two, they are in a situation where they are permanently unconscious. And number three, they're in a situation that is similar to advanced dementia or advanced Alzheimer's disease, where they really can't recognize family anymore. And I asked them to think about how they would feel about medical interventions and how they would want their medical care to be in scenarios like that. I think those are situations where people can reflect without necessarily making binding decisions. I hope that's helpful, and I hope you exercise in your clinical practice a sort of reflection on what works for you and what doesn't work.
Second question here from Darren, who introduced you. So it says, we are fortunate that NIA takes an interest in funding palliative care research. For other neurological conditions, do you have advice on steps that we can take as individuals or as a society to convince NIH and INDS on the importance of funding palliative care research?
I love that question too. I was thinking when I prepared this talk about that, an early slide with the umbrella on it. The early slide, and I thought of you, Benzie. Parkinson's disease is on that slide. So I think an early win for neuropalliative care is to recognize that there are many conditions that are neurodegenerative conditions that are not classically listed under the sort of common causes of dementia, but to recognize that there are many neuropalliative care conditions that include dementia as one of the aspects of the disease manifestation. I think you're the society. This is the society to begin advocating at NIH for attention to other kinds of neuropalliative care research and needs, and to become part of the solution. I will say that I'm delighted that Amy Kelly has taken on a high-level position, someone who's a geriatrician and a palliative medicine physician, and has had a strong interest in neuropalliative care through her own career. She will become an advocate in the parameters of her job at NIA for this kind of research. And I hope this society will become an advocate speaking to individuals high in the NIA administration.
All right. I'll also echo a theme that ties both to your talk and Kathleen Foley's wonderful talk earlier today of documenting suffering as a way to motivate change. And I think whether that be Parkinson's or Alzheimer's or MS or brain cancer, if we're able to document the burden of suffering, I think that creates a very compelling argument for research funding and for clinical funding. So just to bring together those themes, I think that's an important thing that we talk about that more than we talk about prognosis. Third question here is I'm concerned that if we consistently term it suffering versus burden, suffering could further fear and stigmatization of dementia by professionals, the person living with dementia, caregivers, and the general public. So it gets to a question, and I guess, you know, some people might argue even on the opposite side of that burden might be a term that could be stigmatizing or create problems. But what are your thoughts, Laura? Why did you choose the term suffering? What do you have about it?
Right. I love this question because I do think that words matter. And I think that the way that we speak about our field or the way that we speak about our research has all kinds of echoes and implications that we may not even anticipate. I do think that I don't honestly think that the diseases that we're concerned with in neuropalliative care universally should be characterized as causing suffering alone. And one of the battles that we really have to focus on, I think, in neuropalliative care is to recognize that people with all kinds of neurologic diseases can actually experience high quality life. And I don't want to say that a diagnosis of dementia is equated with suffering. But I do think that in palliative care interventions, we should focus on alleviating suffering, recognizing it first, and then alleviating it so that we can enhance people's quality of life. It's a little bit of a tangent, but I will have to say that I've been around people with ADRD of various sort of primary disease processes who experience a really remarkable phase of life with incredible joy. And I've been around care partners who take deep meaning from the experience of partnering with somebody with neurologic disease. And I would really encourage that in our descriptive research, we make sure that we talk about the strengths, we talk about the joys, we talk about the things that provide meaning. But in our palliative care interventions, we want to make sure that we focus on enhancing those aspects of the illness experience and reducing the suffering. I will say also that I worry about the term burden, because burden is usually applied either to a medical intervention that's burdensome or to care partner or caregiver burden. And like quality of life, which I think is inherently defined by the person experiencing the disease, I think that burden from a given treatment or burden from a caregiving experience needs to be defined by the person who's in the illness experience. And I worry sometimes that we should not define that as external observers. So I guess to the degree that stigma, I would encourage that we use the term burden only when it's being defined by the person living with the condition.
This ties on some things that have come up through the course of the day. So that is from Sharon. I'm a novice provider in neurology, just transitioning from a nursing role to an APRN role. I work with many smart physicians who are passionate, but that being said, how can I sell them on early implementation, as many of them still seem to be in the mindset that palliative care equates to death and hospice? And she emphasized that being early in her career and that they may have less buy-in with them.
Sharon, you're just speaking with the wisdom of nursing. So all of us who work in specialty palliative care recognize that social, and I'm a physician, so I feel like I can say this about my tribe. Physicians are typically the last members of the interdisciplinary team to recognize the need for palliative care. I would encourage you to just stick with what you know, because it turns out that nurses and social workers have insight and wisdom into suffering, quality of life, and whole person care that physicians, again, my tribe, need a bit of education. So stick with those physicians, help to educate us. And I think you'll find that over time in your practice, palliative care will be more accessible for your patients.
And another great question that we're having awesome questions today. So this is from Yawari. I'm hoping I'm pronouncing your name correctly. And the question is, how do you, if you do, adjust or modify communication approach of care discussions with the patient with worsening cognitive impairment or communication abilities? She says the example of ALS, who might not be able to conceptualize abstract hypotheticals such as future mobility status or trach or NIV, and really trying to find this balance of making sure that we hear and communicate and engage with the patient, and wondering if you have tips and tricks, tools, visual aids, or other things that you use to make sure that the patient is as involved as they are capable.
Another great question. I love this audience. Really, my approach is to work with the care partner or the surrogate decision maker in this case, and the person living with the disease at the same time. I think it's a really full skill and to listen to what the person living with the disease can and cannot articulate about what's important to them, and then to incorporate the care partner or their proxy decision maker in the conversation. And early on, I listen to the person with the disease, and then I make a careful decision about whether a separate conversation with the care partner is what's needed. This is not an easy skill. It is not a skill that I think is replaceable with a decision aid or a visual aid. I think it's more a recognition that people's capacity is partial, and you want to listen to as much as they can tell you about their values and goals and incorporate that then with an ultimate decision with the care partner.
Well, thank you, Laura. That was a awesome talk, a great summary of the gaps. I have another hour's worth of questions that I could ask you, and we'll for another time. And I also want to thank you for all the work that you've done. And I think, although you may be surprised, I couldn't think of a better person to honor with our Neuropalliative Care Research Award.
Well, I was surprised, but I want to again express my gratitude. This is an incredible society. I was shocked by the award, but it's sitting in a prominent place on my desk, and I'm very, very grateful and look forward to all the work that we do together.
All right. Thank you so much. We will see people later tonight for a screening of Robin's Wish, and would remind people that the director, Tyler Norwood, and Susan Schneider-Williams will be there for a live question and answer immediately following the film. And I hope you, depending on where your time zone is, enjoy a little bit of a break, maybe dinner, and we will see you again soon. Take care.